Hello and welcome to my social distancing version of my class. I'm going to try to make it as lively as possible without other people. I'm going to go over all the scenarios and I'm going to try to use all the things that I have to make it as realistic as possible for you. Hope you enjoy. Let's begin with respiratory assessment. As with each class, I have a disclaimer. You can read that on your own. It's basically a common sense disclaimer that says, whatever I show you, make sure that you check your policies, scopes of practice before you do these things. My teaching style is I like experiences. Unfortunately, we don't have a class here to share experiences. But other than that, everything that I'm showing you is evidence-based. Let's go over reasons for shortness of breath. There's a lot of different ways that patients will present. Why are they having this shortness of breath? Why are they having dyspnea? Is it because they're hypoxic? We check their SAT, they're sat in the 80s, and they're turning blue. We know what to fix. Is it because they're not ventilating properly? Patient who has pneumonia, their COPD, asthma, they're not moving that CO2 properly. What can we do to help them? And we'll know how to fix that. Metabolic status. Are they breathing fast because of some kind of metabolic issue? Or that DKA? Are they trying to compensate for this low bicarb? Cardiac. Every other patient comes in with chest pain, they're going to look like they can't breathe. And what are we fixing? Are we going to fix the pressure in their chest? Or are we going to try to give them an albuterol treatment? Pain and anxiety. Is this patient flipping out? Are they breathing fast because they're anxious, having a panic attack? Or are they in a lot of pain? Are they breathing in a way that it's fast because they have a lot of pain? So we need to know, try to get to a point where we can assess it, and so we're treating the right thing. When looking at your patient, you're going to look at things like accessory muscle usage. You'll see this patient here is tripoding. This is a typical COPD patient who they have these kind of tactics, and because they have to live with this disorder, and so sometimes they'll do things like pursed lip breathing, but you'll see this tripoding for these type of patients that have these worker breathing issues, COPD, asthma. We also want to look at their intercostal, if they're using a lot of respiratory accessory muscles. Chest symmetry, we're going to want to take a look at how are they breathing. Are they breathing, are both sides going the same, or is one side going this way? If we look at our first x-ray, you can see that we have a massive pneumo on the right side, and that could give us a type of breathing pattern where we're not going to see much movement on that affected side. Also, if we take a look at that other x-ray next to it, we have quite a few ribs broken there. We'll have a flail chest, and so we'll have either paradoxical breathing. Okay, so we're going to look at that. That's part of our assessment, is to check take a look at the chest, see how it's moving. We're going to go over breath sounds. Now, the thing about breath sounds is it's taught many different ways. If you're a nurse longer than 10 years, you were taught something different. You were taught bronchi, rales, you're taught all these different breath sounds. But now it's kind of taught with these 4 basic breath sounds. And really, they're all, really the most important thing about breath sounds is what do we hear, and then what are we going to do about it? How are we going to treat it? So let's not get too hung up on what the breath sounds are called, because different people call it different. And so it's going to be a way to communicate when we talk about other breath sounds. So I'm going to teach you these breath sounds in this terminology, but then we're also going to learn what it's also called so you can communicate. Breath sounds, first we're going to go over is wheezes. Wheezes these are one of the breath sounds that you're going to hear a lot. It's going to be the most dramatic, and everything at first kind of sounds like a wheeze. You hear this whistling. We can listen to that one. Sound. Is it a wheeze? Okay, you're going to hear this musical in and out. Okay. But a lot of things sound like a wheeze. Fluid in the lungs may sound like a wheeze, right? Forward aspiration may sound like a wheeze. But how are we going to treat this? Are we going to give a bronchodilator? Because if we have COPD, asthma, and we have this tightness going on, if you look at these airways, see how they're getting tight, that's how we're going to treat this wheeze. We're going to give a bronchodilator. Now, you have a fluid overloaded patient, and they have what kind of sounds like a wheeze. Maybe albuterol is not going to help them. Okay, so we have to know how we have to treat this. So a true wheeze is typically expiratory because you get asthmatic. You get this air in the lungs, but on the way out, it's tight. Okay, so you're going to hear the musical note of the air moving through the lungs on the way out. Coarse crackles, and these are the patients who have a lot of obvious things. They hear rocks in their chest. You hear things rattling around, and this could be a lot of things. It could be a lot of secretions. It could be fluid overloaded. Let's take a listen to this. And this will be associated with a lot of different things. I put this graphic bronchi in the bronchi because to help you remember that this stuff is in the large airways. This stuff is stuff that you could cough and clear. It's also known as rhonchi. You'll hear older docs and older RTs and nurses use the term rhonchi or rhonchorous when they're talking about this breath sound. And it's the same thing. It's obvious, coarse sounds that you could maybe cough out. Okay? It's associated with a lot of different disease processes. So coarse crackles or rhonchi. Fine crackles. Now this is a patient who's typically fluid overload. And these are breath sounds that are sometimes in the bases. They can be upper though, once you get overwhelmed by fluid. But the fine crackles cannot be coughed out because this is fluid and this is pulmonary edema in the lungs. And if anything is coming out, it's frothy pulmonary edema. Okay, but these are not secretions that are stuck. This is just air passing through the fluid in the lungs, and it'll sound like fine. It'll be fine crackles. Let's take a listen to that. And you'll hear this with CHF. You'll hear this with pneumonia. You'll hear this with a lot of different things. You could even hear this from a patient who missed their dialysis appointment, and they come in and they sound wet, and you'll hear this crackling going on, it's fine crackling, and it'll sound like maybe we need to maybe suction this patient, but there's nothing to suction because it's just fluid that's bubbling up and air is moving through it. Rails in the tails is the graphic I gave you to remember. Tails meaning the end of the airway, which is our alveoli. Diminished breath sounds. Now, this is probably the most recorded breath sound. It's non-committal. You can come in, you could, they're diminished, I don't hear much. That might be true in some cases. But let's make sure that when we're charting or recording a diminished breath sound, that it's not because of something wrong. So for instance, a collapsed lung. If we have a pneumothorax, they may have a diminished right side or something like that. So we want to make sure that if we're witnessing a diminished breath sound, we make sure that's not for some reason that we need to fix immediately. We could have it with frail elderly patients. We could have it with a thick chest wall, a very bariatric patient. You may not hear much movement. You could have it with pneumonia consolidation. Also, one thing that's to look out for is late stage CHF. You can have a patient who is so fluid overloaded that they're not moving air anymore. Okay, before they were wet and they had rales and they had coarse crackles and rhonchi, but now they don't have anything because they're not moving any air. And so, and you could, when you check their X-ray, you'll see this big whiteout. And so that's one thing we want to look out for diminished. Also, things like a pneumothorax. Stridor. Now, stridor, this is a breath sound that does not involve the lungs. We're talking about the upper airway. Let's take a listen to that. It's caused by a swelling of the upper airway. We can have this from many things. We can have it from anaphylactic shock. We can have it from trauma to the airway. We can have it from someone who self-extubated. Also for kids, croup. We can have some epiglottitis. Some of the times this is an emergent situation, and we have to emergently intubate. And sometimes we can just fix it with racemic epi. But for the most part, this has to be dealt with immediately. And the way that we'll also take this breath sound is we're going to listen to the upper airway. Okay? And we also may get different views of the x-ray. We'll get a lateral neck, soft tissue, CTs, things like that, to double check to see what we're seeing when we hear this stridor. So, end-tidal monitoring. So we're going to use this for a lot of different things, not just for respiratory issues, not just to see whether CO2 is. We're going to use it for a lot of different life functions. For instance, we're going to use it for venous return metabolism. We also use this for confirming ET2. It's kind of the gold standard for checking ET2 placement because the threshold for it is way lower than the colorimetric capnography that we use. So if we see any kind of waveform, we know that we're in the airway. Now the way that end-tidal works is it takes a real-time reading of our CO2. And so our normal CO2 is between 35 and 45. And this is what the American Heart Association wants us to consider a normal end-tidal. But I think it's a little bit lower because we have parts of the lungs, or the airway, the trachea, and the main stem that don't participate in gas exchange. And so this will be considered dead space. So that may account for about 5 to 10 millimeters of mercury, less than the blood gas would give us. So if we see a end-tidal of 30, so we won't be worried about that. And really we shouldn't be worried about any of these numbers. We should be using this as a trending tool. So how are they doing? If they're trucking along at 30 and then all of a sudden they're doing 15, maybe we need to worry about that. But we're not going to obsess over it's 30 or even in the 20s. Okay? We're also going to use it to assess for high quality chest compression. So if you look at our diagram below, we have lungs takes the O2, goes to the tissues, go to cellular metabolism, and then its CO2 is expelled. Okay? Now, think of the CO2 as exhaust for living. So if you have a patient who's living, they're going to give out CO2. The second that we cease living, this is the second we cease making CO2. So it's this kind of life gas that we're going to read, and we could do a lot of things with whatever is expelled by this person lifetime. Our waveforms look like this. They're kind of box shaped, and if we get this waveform, it means we're getting a good consistent reading. Now there's different types of waveforms that we'll look at. For instance, if the first one above dyslodge ET2 or apnea, we'll have a reading and then we'll get a sudden flat line. Okay, that can show that we have an ET2 that popped out, or the patient suddenly went apneic. Below obstructive airway, we'll see this kind of a shark fin waveform. It's indicative of bronchospasm and asthmatics, all this kind of shark fin waveform. During ROSC, you'll see this sudden increase. So if we're doing compressions, 10 to 15, all of a sudden we get an end-tidal of 32. I mean, it shows that they're actually breathing on their own, and then you got spontaneous circulation back. And also another one breathing around the ET2. We'll see this kind of angled downward slope for an adult or that has an ET2 that's too small, or children usually have a cuffless ET2, and you may see this. So let's go over a couple of scenarios. Got a male 62, status post-laminectomy on PCA pump, respiratory rate of 16, status 95 on 2 liters nasal cannula. We check our end-tidal with 36. And if you look at that AWRR of 16, that's our respiratory rate, and that's kind of one of the most accurate readings you're going to get because it's from the airway. The patient starts dropping the respiratory rate to 6. End-tidal is alarming. Now, what would you expect the end-tidal to be? Would you expect it to be high or low? Now, think about this. If you have, say, you have a stack of CO2, okay, and you have to get rid of it, okay, and then you stop getting rid of it, what happens? It stacks up. So the breathing that you're doing is getting rid of it. Okay? So if you breathe less, you're not getting rid of it as fast, so it stacks up. So what's going to happen with this end-tidal? It's going to be higher. So your end-tidal is 62 because he's not blowing off as much CO2. We have a male, 58, post-PEA arrest, intubated in the field, stable in the vent. Heart rate is 80, blood pressure 110/60, status 94. Here's our vent settings: respiratory rate of 14, tidal volume 500, people 5, 60%. Not over breathing the vent, which means he's just breathing what we're giving him. So he's breathing 14.
Set at 14, breathing 14. APG says 737, 41, 98, 21. We have an end tidal of 33. Looking good. All of a sudden we get this low end tidal alarm beeping. Heart rate is 120, sat is 92. And then we get this. We have an end tidal of 17. So what's the first thing we want to look at? Is we want to look at the respiratory rate, right? So we double check. He's breathing 14. He said at 14, he's breathing 14. So it's not that. So why is his CO2 so low? So we check all connections, make sure they're intact, make sure there's no leaks, and we determine that it's not respiratory. What else could it be? What's going to make his end tidal drop like that? Circulation, right? So what's next? Blood pressure. We check the blood pressure, 72 over 40. 2 minutes later, no pulse, beat the rest. CPR started, and that keyed us off into this code because that went off, that alarm, the end alarm went off before the blood pressure cuff fired. Compression started, concerns about quality of CPR. We have an end tidal of 8, okay? So what do we need to do? We need to get deeper compressions, more recoil. Technique is corrected, more depth with compressions, and here we have end tidal 16. Female, 39, status post knee replacement, having shortness of breath, chest pain, heart rate of 130, elevated D-dimer, respiratory rate of 18, set of 93% in room air. We have an end tidal that's normal, 39. Respiratory rate increasing from 18 to 35. What would you expect the end tidal to be? Okay. So this is a tricky one because you never know. I mean, if all things considered, respiratory rate increasing should mean that this end tidal is lower. However, this patient probably has, from the things that we're looking at, they may have a pulmonary embolism. Okay, so we check the end tidal and it's the same. Okay, positive CTA for pulmonary embolism. So what's going on is this patient is trying to compensate, but they're not ventilating. So they're trying to blow off the CO2 by breathing higher, but the clot is not letting the lungs participate in gas exchange. So we'll have kind of the same CO2. It's a compensatory respiratory rate, and it's one of the many things that we can look at when we're diagnosing for a PE.